All right, guys, we have a fantastic video today for the Optimize MCS channel. We've got Chris Brown, the head of CHIP CTO at Swedish in Seattle. He's going to be walking us through a really cool case and some best practices for large bore closure. And I think we wanted to address this topic. You know, it's basic, but I think it's very important. When you look at the outcomes from danger shock, while there was a 10% absolute reduction in mortality for patients in shock, with ACS, there was a high rate of vascular complications. You know, there was a 21% rate of major bleeding versus 11% in the other arm, and I think that's very discordant with some of the data we've seen. For instance, from Protect 3, there was only a 1.8% major bleeding rate. So I think a lot of this discordance can be resolved with just adopting best practices for large bore closure. And Chris is a master of this. For those of you who don't know, Chris does about 50 or 60 Impellas a year. He's very, very high volume, and I think he's going to walk us through some great tips and tricks today for Impella and large bore access best practices. So, Chris, take it away, bro.
Thanks, man. I really appreciate it. Thanks for having me. So I have a case here. This is a 82-year-old lady with sort of the usual risk factors. She came to another hospital's emergency room quite short of breath. EMS brought her in and essentially had to intubate her as they were like exiting the vehicle because she was just had gotten to the point of sort of no return with her breathing. She had these angiograms. You can see she has diffuse LAD, severe calcified disease, left main bifurcation disease. She's in sort of a bad place. She has a non-dominant right coronary. They did take some iliofemoral pictures because they were actually contemplating placing an intra-aortic balloon pump at the hospital. However, they took these two pictures and you can see what she actually probably has is severely stenosed iliacs. They felt that it was occluded, but I think based on that competitive flow, we felt that it was probably just severely stenosed. She was brought over to our center so we can have a discussion about whether she's going to be a high-risk PCI or a CABG patient. She underwent a CT angiogram of her aorta and her lower extremities, and ultimately she was felt to be too calcified for bypass grafting and felt to be sort of in a bad place for as a surgical candidate anyway, based on her age and other comorbidities. Her CT angiogram did reveal that she had small channels in her iliac vasculature, and of course she's NYHA class 4 at this time, so we need to do something, and so we need to make a plan. And so we made a revascularization plan that said, you know, we felt like she needed support in order to undergo revascularization based on her extremis, frankly. We knew that we needed to address her iliacs in some way. We looked and her subclavians were not adequate in size for Impella placement there, but we felt like we could modify her iliacs appropriately. We really felt that we were going to have to be upfront with atherectomy here based on the degree of calcification. And more importantly, we really wanted to keep this procedure time low because we know that we may be a little bit occlusive or ischemic to her leg with our large bore sheath while we're working. And so we're going to opt for what we think is the simplest left main bifurcation strategy, as well as upfront atherectomy, so we don't waste any time with delivery of equipment, whether that's lithotripsy, stents, etc. And so,
hey, Chris, a couple points though, too. I think for a question, do you ever do distal protection with cases like this where there's bad iliac access and you're worried about ischemic time? Will you ever put in a distal perfusion catheter with Impella?
Yeah, we have, but I find that generally speaking, at least the current side ports of every sheath that exists is inadequate in diameter to allow for really good perfusion of the lower extremity. It works with ECMO because the flows from the ECMO T piece is very high, right? It's several liters per minute of direct flow through the side port, so it overcomes the resistance. But when you put something like an arrow in for anterograde perfusion and you connect it simply to the side port of a peel away that you already have a repositioning sheath, you have an Impella and your companion sheath through, you really don't have enough flow to really adequately perfuse the leg in a pretty meaningful way. And frankly, I've had several of them that just thrombose within like the first hour. And so really our goal is to work as efficiently as possible. You can have lower extremity ischemia for short durations and do fine. We know that from acute limb ischemia, and we get some flow around the sheath. You know, we're going to adequately revascularize this to a size where we're not going to be completely occlusive, hopefully. But we rarely use those anymore. We used to, but I just found that they weren't really doing anything. And really, I think revascularization or alternative access, whether that's axillary or otherwise, is sort of our mainstay now. So in this case, we just went forward with revascularization. We performed intravascular imaging. We performed lithotripsy. and a regular balloon angioplasty, you can see the lithotripsy balloon here on the right. We get very good expansion over the first 60 pulses. This is actually the second run. So, we push the balloon forward, do the next 30 pulses, and we get really good expansion. So we feel like we're going to get adequate ability to dilate and pass our catheters. And then,
Hey, Chris, I think the other benefit of this approach, as opposed to an axillary approach, especially in a sick patient like this, is you've revascularized the iliacs now. If you have to bail out to ECMO,
yeah,
if something goes really wrong, now you're actually going to have access to do that. I mean, it's not perfect access, but I think that's a real benefit. If you have the choice between revascularizing iliacs, especially relatively straightforward ones like this, and going axillary, my choice is always femoral, because if I have to put an ECMO cannula in there, it shouldn't be a big deal. So I think that's an important point
yeah, I
too.
think that's a really, really good point. You can see here this sheath goes with limited to no resistance. We're on a stiff wire, of course, that we always implant on stiff wires for all of our sheaths. And, if you need to, you can dilate actually with the other peel away sheath dilator. It has a hydrophilic coating on it that can sort of lubricate the path. You can take that out, and then your peel away sheath, which also has hydrophilic coating on its dilator, and the peel away sheath itself can then pass a little bit easier if you need that. So if you need to dilate, I actually normally dilate with the other peel away dilator because I find it to be it's actually a really good product. So we went ahead and did that here.
Did you use the long one or the short one on
I
this?
use the long one for pretty much everything. We use the short one
Okay.
as the dilator. We rarely use the short one anymore. I just like to know that we're safely in the abdominal aorta with the device. If we're having to go through any degree of stenosis, because I think it moves the Impella more easily. If you put the short one here and you're short of the bifurcation and you've revascularized it, the Impella itself isn't exactly smooth, right? I mean, there's lots of little parts to it and stuff, and those could get hung up on things, especially in revascularized territories. And I don't really want that. So we want a smooth pathway for the Impella up into the abdominal aorta, and then we can deliver, through the abdominal aorta, which is adequately sized, even though in this angiogram you can see it's got clear atheroma pretty much everywhere.
Hey, Chris, what's your bailout, since you don't really have a left to go through? If something goes wrong, what would your bailout be for this if the groin blows up?
Say that again. Oh, meaning like how do we balloon tamponade this, you mean?
Yeah, like if something goes wrong with closure, what would
We would
your
go
kind of
antegrade. So when we close this, I'll show you, but we have wires and catheters in position if there's something that goes wrong. And so we would just go back antegrade the way that we came.
got it?
We can obviously revascularize the left, and in a handful of cases, we have actually done that to prepare for catastrophe if we needed to. But I, generally speaking, just use the same side now. As you mentioned, we've revascularized it to the point where we could implant easily 14, 16, 17 if we had to ECMO cannula. And so we feel like we're in a sort of an adequate position from a bailed out hemodynamically, and from a balloon tamponade or other standpoint, we can easily deliver equipment now because we've modified it. You can see here,
That is
this is
natural, dude. That
not
is
good coronaries, is what I call this. Really calcified. These are obviously somewhat better angiograms just because we have a guide catheter, so we're able to deliver a lot more contrast. We do a lot of our work in 7 French guides, whether femoral or radial. In this case, this is a companion sheath case, which we're really happy with. We think that's one of the best things that's come out in quite some time. It's quite deliverable. It's hydrophilic. We really like the companion sheath a lot here. So as I said,
love.
we were going to be upfront with atherectomy here. We went Rota left main to LAD. We felt like if we modified the left main plaque, we weren't going to have to Rota into the circ. So we went Rota left main to LAD, got down that, went ahead and wired both ways. You can see here we've modified the plaque quite dramatically. It doesn't look great yet, but we've modified the plaque and made a path for us to sort of move on with our day. We went with really high pressure non-compliant balloon up to 18, 20 atmospheres. We don't like to go over 20 much anymore. If I get to 18 and we don't get relief, we normally go directly to lithotripsy. We got pretty good relief in the circ there. We had to go to lithotripsy in the LAD, of course, and ultimately we ended up doing lithotripsy of the left main into the circ as well. The whole length of that. You can see here on IVUS of the LAD, lots of plaque, somewhat eccentric, a lot of calcified fractures and stuff. There's circumferential plaque as well, of course. All of it's really well modified, though. This is us kind of hanging out at the left main bifurcation, trying to understand exactly how we're going to do our TN protrusion or our T stenting. And so we went ahead and stented the LAD itself first. And our plan here is actually to do a reverse TN protrusion. So it says tap, but it's actually a reverse tap. And the reason is that we're going to make the tapping or the teeing stent into the main branch, which would normally be the LAD. Normally the side branch is the circumflex. I like this technique for multiple reasons. The first of which is that it's much easier to recross into the LAD than it is into the circumflex. Some people would say, oh, well, that's a more important territory. And I think that's true. It is important. But I find that since we're going to be able to protect with the wire, we're going to stent across, we're going to have a wire in place anyway if we need to rescue it, and I think that you just get better cell opening at that sort of outer curvature of the circumflex to left main, and it's a direct straight wiring. I really think the deliverables are just much better, and it's just much faster. And so that's what we went ahead and did here. And we're going to tee up or tap as little extra metal as possible. And in this case, since the angulation is such, that's essentially just a T stenting. And then we found what we felt like was a decent, healthy landing zone. A lot of modified plaque. We're going to post dilate this stent more aggressively after we're done, but this is just sort of an IVUS after stent implantation.
That looks great.
And we like it. I mean, we're circular. There's a lot of plaque outside of the stent. And so I think people have to be really careful though, when they measure these things. You can't just go measure the media to media again, and then go ahead and post dilate this. You will rupture these arteries. You're not going to get apposition of the stent against the softer plaques. It's going to push that soft plaque out of your way, but you're always going to be able to see that. And it's always going to be bunched up against the media. Whereas against the calcification, it looks like the stent is up against the wall of the artery, because the calcification prevents you from seeing through it, and so you can't see what plaque is behind it. So the stent will always look really well opposed, well expanded against calcium, and will always look like it's maybe a little undersized against soft plaque. It's not undersized. You go back to the original reference and it's totally adequate. It's just that you push that plaque to the side. So that's a mistake that people make, and it's how people perforate. So I think it's important to remember that. And these are our final results. We really like this from a technical standpoint. We think we got a really good result here. She's got great flow. We think she's going to do well. She's able to wean the Impella. And then we move on to...
So take me through that, Chris. You finish this complex case, you can actually see the contractilities better post-revascularization. What's your decision-making for whether to leave the Impella in or take it off? Because I don't think we talk about this a lot, but so you've got the Impella in, how do you decide?
We do something, I think a little unique in that we actually set up the LVEDP on the device, which almost nobody does, and then we monitor that, or we track that to the end of the case. Other people do things like right heart catheterization and then a repeat right heart cath, which I think is totally reasonable. We just think that it's a little bit easier to set up the LVEDP on the Impella itself to start, and then be able to track or monitor that sort of throughout the case. And if it's not getting worse, or it's improving, and in her case was improving, we then think that we can safely wean. And we, with our anesthesia colleagues who support us in these complex cases, we then work through a weaning strategy of between 2 and 5 minutes every 2 P levels, and we work our way down. And as long as they hemodynamically tolerate that, then we go ahead and proceed with explantation. We think that, and I find that actually most people who we do this with, they actually increase their pulsatility and pulse pressure width as we wean the Impella, because the Impella really does unload the ventricle and it does decrease the preload. So in the Starling curve, you actually aren't getting as much contractility when you're unloading aggressively, and you don't need to, because the Impella is doing a lot of work. But we actually find people become increasingly pulsatile as we wean them. If they do not become increasingly pulsatile, that gives us significant pause, and those are people that we really think about switching to our repositioning sheath and sending upstairs to recover within Impella for a day or two or more.
Some people in total extremis, you notice you put that thing in and it's like their heart's just like, all right, fuck it, I'm done. I'm not going to pump anymore. And like they go completely flat. And I'm like, oh, that's a really bad sign. I feel like those patients, you're probably going to have to leave the Impella in.
No, I
once they just,
agree.
the contractility just goes away the second you put it in,
Absolutely.
So, all right, cool. So you've done this complex case now, you've weaned the Impella, you've decided to take it out. Take me through your exit strategy in this kind of complex vasculature.
So we exit actually the same way in everybody, complex vasculature or not. So what we do is we remove our companion sheath. We then remove our Impella, of course. We wire our PLOA sheath, and we then deploy our per closes over the wire. We don't lock them, but we do deploy them. And we then exchange that for a 4 French sheath. We advance through that 4 French sheath, a 65 centimeter 4 French pigtail, and we perform abdominal aortography with runoff to ensure we have no trauma to the abdominal aorta. The iliac vasculature is safe. The CFA and the closure site is safe. And we haven't embolized. We don't have any dissections that need to be addressed. There's no small perforations from calcific nodules or other things. And in this case, it allowed us to understand our revascularization as well, which I think is adequate and quite good. I mean, she went from no anterograde flow to anterograde flow. You can see on the left side, she still has a mostly collateralized flow. There is a small channel there on CT scan, but
is that Is that a 4 French sheath and a
Yep.
pigtail? It looks like you have a
Yep.
pigtail.
So it's a
Okay, I
4
love
French
that.
pigtail.
So do you lock the per closes or do you just pull them
I don't
down?
lock
When
them.
do
I
you
just tighten them down and leave them. That's totally adequate in my experience to keep the hemostasis around the 4 French sheath. Once we know that this is good, in this case we feel like this is a good result, then we go ahead and just wire our pigtail again, take our sheath out, tighten our perclose over a wire, and then once we have hemostasis with that, we take our wire out and then lock our percloses completely. Some people lock one of the two percloses. We're a two perclose site. I have done one perclose, but then we've had problems when we were trying to bail out with things. And so I typically deploy two precloses. And I've been increasingly changing the angulation from being sort of the 10 and 2 to more like 11 and 1 or less. I think you get less pinching of the arteriotomy, but just as good a hemostasis. In this case, it was probably a 10 and 2 because you can see that there's a little pinch in the CFA. Nothing that's going to change anything for her dramatically, but it's still something that you see when you take these closure shots. But this is also reassuring for the patient on the floor because she's gotten sedation, maybe she's gotten some anesthesia. And, if there's some hypotension, you have pretty good confidence that one, your stick wasn't retroperitoneal anyway, but two, that no other thing happened with implantation of the peel away or the Impella itself, at least in the abdominal aorta, to cause an RP bleed. You know that you're not bleeding from your access site. You just have sort of some reassurances, and I think it's good for patient safety. So we really like this a lot. And we explant all of our Impellas in the cath lab. We don't do any at the bedside any longer for this exact purposes. We rewire the repositioning sheath. We deploy percloses. We put our 4 French sheath in. We take pictures for everybody, and in particular when the Impellas have been in for a while, because you don't want some sort of thrombus or something to develop and you did not adequately address it. So
from a liability perspective too, I think this is huge because you can document the angiography at the close. I know some people take an angiogram through the Impella sheath just to make sure the iliacs are okay, but that's super elegant. And Chris, when do you give protamine? I know we'll
Oh
talk about
yeah.
this maybe a little later.
So I give
At what point in the closure
protamine after the
process?
Impella is explanted because I don't want it to clot. But as soon as the Impella is explanted, we deliver protamine. We give sort of medium dose between 30 and 50. Um,
Yep.
I think that and I think the data supports this quite dramatically, that if you appropriately preload people with antiplatelet therapy, that everybody should get protamine, especially in complex PCI. But when you look at the CTO data, the University of Washington did this. They were able to show that your rate of tamponade, even if you have perforation in complex PCI, CTOs, et cetera, is dramatically improved if you just reverse with protamine. So I think you guys all do this in large bore stuff, maybe more routinely than we do in PCI, but I think we have to sort of get over that hump because it really is, it's a very good thing to do. And it's probably really in the patient's best interest long term.
Yeah, I mean, I think the thing that really brought it home for me with protamine was when I looked at the data, there's actually STEMI data for protamine. Like giving patients with acute STEMI protamine after, of course, they've been appropriately preloaded.
Yeah.
And so if protamine works in that population, it's going to work in every
Yeah.
population. And having done it in, 1,000 cases, I've never had an issue
Yeah.
with it. And, you get occasionally an exaggerated protamine reaction. There's always a small chance of getting a catastrophic protamine reaction, but I think the risk versus benefit, I think it's one of the most underutilized bleeding avoidance strategies that exists. And it's not just for large bore. You put an 8 French sheath in, you're still going to have much better hemostasis. And also important, you're not going to get called all night with
Yep.
the fucking oozing groin
I
that is the
completely
big
agree.
resistance.
Regardless of
So
the size of femoral arteriotomy that we perform, we give protamine.
yeah,
So
I love
if
it.
we've given
Okay, so that's a
heparin
best
and you have a femoral arteriotomy, you're getting protamine from us for sure.
practice. I
You're
love
not
it. So
calling
now
me.
we're going to get into the actual best
Yeah.
practices of femoral
I,
access. So take us
Yeah.
through that.
I mean, I think it's important that we are all constantly improving at everything we do. I think that's why Murmur is great. I think that's why people like Murmur and why the operators are on Murmur is because everybody's learning from each other. And I think it's important that we continue to improve our femoral access skills. I think we've come a long way even in the last 6 or 8 years with regard to how we address these things, protamine being a huge part of them. I think the way that we deploy multiple percloses or even single perclose closure, so you don't have so much pinching at the arteriotomy. I think there's a lot of really elegant things people have been able to do. And ultimately, this is going to help your program. It's going to help your program grow because patients are going to have good outcomes. They're going to be happy. Referring provider is going to be happy. It's going to be what's best for the patients medically as well. It also is going to reduce the cost and length of stay and other things that are important to the administrators who are, constantly harping or following you around to get X, Y, or Z out of you. So
It's also a quality of life. Like
yes.
when I realize that if I have meticulous, pristine access and closure, my quality of life is going to go up. Like,
Yes.
it's great for the patient, great for the hospital, great for everything. But if you think about it, what is the biggest challenge we have in terms of getting called, coming back to the hospital, dealing with complications? It's vascular access.
Agreed.
So if you get really good at vascular access, it's going to significantly improve your quality of life.
100%. 100%. There are obviously some anatomical considerations in large bore, even non-large bore. I mean, calcium is a problem. We have to modify or deal with that. You saw that in this case. Vessel size, you need adequate vessel sizes. And we IVUS all of our iliac vasculature before we implant large bore sheaths for these complex PCIs. Just to ensure that there's adequate size, because about 2 or 3 times where we really felt like we were borderline, and even in people who didn't have iliac vasculature with disease in it, we were too small to implant, and so we were unable to proceed with that. So we are really sort
What's
of
your cutoff first?
So our
5?
cutoff is 5. I think the cutoff may be technically 5.5, but we use 5. We feel that in a non-disease vessel, 5 is acceptable, and in a disease vessel, you need to be above 5.5. The reason being that, of course, you get better stretch, or the adventitia tolerates stretching more in a non-disease vessel than it does in a disease vessel. In a 5 non-disease vessel, you will sometimes get retrograde dissections. These are not something that you need to do something to, generally speaking, because the flow is opposite the dissection, and so it will tack the dissection up, but it is something to be aware of when you're doing that. Plaque, obviously you need to modify plaque in order to get your equipment where you need to go. And then tortuosity is really not your friend. It's the reason we use the long peel away sheath. It's to try and help deal with tortuosity. I will say in extreme tortuosity, that peel away sheath is very thin walled and can kink and can become difficult to manage. And so a way to overcome that is to use your own larger 16 French sheath of some kind that has a thicker wall to it, whether that's Cook, Medtronic, whoever, and that can allow you to deliver your Impella. Obviously, you can't no longer use it for single access work because the membrane isn't correct, but you can at least deliver the support the patient needs through somewhat tortuous segments. I rarely find that the peel away sheath kinks in a way that I can't sort of jiggle the sheath back a little while I'm pushing the Impella through to kind of right size the oval and allow to do the work that I want to do. But it is a little thinner walled, and so it's something to be thoughtful about. Of course, we all know about these anatomical landmarks. It's just really important that people understand that what we're really compressing against is the pubic bone. So what I care about is where's the top of the pubic bone, where's the bottom of the pubic bone. I want to stick an artery in that space. If it's the SFA and it's adequate sized, it's the SFA. If it's the profunda and it's adequate sized, it's the profunda. I am not interested in or dedicated to always being above the bifurcation if the bifurcation is really high and in my compressible space. I'm most interested in a compressible space in an adequately sized vessel, because it doesn't matter what you call it, as long as it's in a location that you can compress the artery, which is to achieve hemostasis, and it has the right size for what you're trying to do. Anything else is somewhat superfluous, or you don't really need to worry about. So my bony landmarks are this pubic bone, and where is there somewhere of an adequate size. Now, if the bifurcation is just at the bottom of the pubic bone, am I going to stick the SFA instead of the middle of the pubic bone for the CFA? No. But generally speaking, your landmark needs to be those bony structures where you can perform hemostasis. Because the reason people say don't stick the SFA is because generally speaking, the SFA is in a non-compressible space in the thigh, and that's how you get pseudoaneurysms. And so it's really more an avoidance strategy for that. But if the SFA is in the compressible space, or the profunda is in your compressible location, that's where you want to stick. And that's really what best practice is. It's to stick where you can actually get compression, because in the end, as you mentioned, what we really care about is hemostasis here. So that's what you need to worry about. We obviously,
Yeah, and I think the other thing is co-register where you stuck your micropuncture. And again, I know there's a debate about micropuncture versus the big needle. It's easier to see the big needle on ultrasound. I like micropuncture still for large bore access because I can re-stick if I go on fluoro and I see where I stuck the artery and I don't like where it is, and I can see where the wire's going because the micropuncture wires like to go in the lateral circumflex. So I think it's important once you stick, make sure it feels right. If you feel like you're having to push really hard to get that micropuncture needle through, it's probably not going to take a perclose. And co-register where you stuck on fluoro to see exactly where it is and where the wire is going to make sure you're in a safe spot and everything looks kosher.
I couldn't agree more. The co-registry is critical. You really need to do 2 things, right? You need to locate the landmarks. I mark those landmarks using a pen, actually, under ultrasound.
Me too. Yeah, I still do that.
I then move the camera away and I perform ultrasound guided access using a micropuncture, as you mentioned, because we really do need to visualize the needle going into the artery, because that's really where the arteriotomy is. I then again co-register where we are fluoroscopically just to see where on the bony landmarks we feel like we've entered the vessel. And if I don't like it, I'll take it out and I can hold pressure. And a micropuncture is a small enough hole that you can hold 2 minutes of pressure and achieve hemostasis. And then you can move on to
Yep.
your next stick, whether that's lower or at a slightly different angulation or whatever it is that you need to do. But I really think it's critical that you're using ultrasound and bony landmarks, and you're using them both, because that's really how you're going to get the best outcome here. And with regard to the angulation, in these larger bore cases, of course, we would like the angulation to be a little bit less than what sort of quote unquote standard at 45. We don't want to tear the arteriotomy. And then, of course, these large sheaths need to make that turn. And so that can be a little difficult. I personally dissect to the level of the artery using blunt dissection. Some people don't like doing that because you do have little capillaries that can ooze and stuff. We just treat that with lidocaine with epinephrine, and that resolves that issue. If we do have any oozing from little tiny capillaries or something in the subcu tissue, but I really find that you can really guarantee both that your percloses are already all the way down on the artery, that you have a clear path, that you're not involving the inguinal ligament in some way if the patient's pelvis is rotated and you had to go near it. And I think you get better closure that way. So we bluntly dissect down to the artery. I know that not everybody does that, but we think that that's
I like that. Very surgical of you, Chris. But yeah, and I think that the key point with ultrasound, and it took me years to get really good at ultrasound, see that needle going in. If you don't see the needle tenting the top of the artery, just like this video, you don't know where that needle entered. And if you just do this, your access complication rate is gonna go to almost zero, because it's clean, you're at 12 o'clock, and you're going to get good closure if you have good access.
Absolutely.
So I think this is critical. And sometimes, sometimes I go on vacation and I get back and I have a large bore access case, and it takes me 5 minutes to see that, and that's okay.
Yeah.
I'd rather take 5 minutes and make sure it's right than just use the ultrasound as an artery finder, and I get flashback. I'm like, all right, we're good.
Exactly. And actually, to your point, that's actually one thing that concerns me sometimes. I'll be trying to find my needle, and then I'll look down and I do have flash, and I'm like, well, where is my needle? Like, I'm moving my ultrasound, trying to make sure I'm holding my ultrasound right where I want. I'm trying to angle exactly where I want to stick. I've clearly stuck below where I wanted to now. Because I didn't get to see it enter the arteriotomy. Now, sometimes I'll wire that and fluoroscopically check on it, see if it's adequate, and we may take that. But most of the time we'll just say, okay, and we'll walk away. We'll pull it out, hold 2 minutes of pressure, readdress, and change where we stick the skin, because it doesn't, that's not what we want. We want to see an anterior wall stick, and we want to see where we're at. And I think you can adequately see the micropuncture in pretty much anybody with a reasonably good vascular ultrasound. The micropuncture needles on the tip of them now have a very ultrasound lucent coating or whatever on the metal. And so I think you can see them adequately. I don't use Cook needles. We don't have them anymore, actually. I think it's fine if you would like to use them, as long as you're doing all the other things correctly. I think the data probably supports that, although it's a little bit biased because the people in those studies who use the Cook needle are like ultra high volume, like Cook needle users. And so I don't know that if you're just starting out and you've used a lot of micropunctures, you should really change. I also like to be able to take my femoral arteriotomy pictures with a smaller enough sheath to hold manual pressure.
Well, I think just a lot of this taking the time to do this right explains some of the discordance in the danger shock data versus some of the other Impella data. Because, when a patient's in shock, when they're sick on the table, you're in a rush. And when you're in a rush, you don't adhere to kind of slow best practices. But I think those are the patients you should adhere to it the most in, right? The sickest patients, the patients where they're the highest risk of bleeding. Those are the patients where, hey, if it takes, a couple boluses of epi or neo just to stabilize them while you're getting good access, it's totally worth the time. So I think that's really the biggest part of the difference between danger shock and some of the other trials, is these patients were sick. The operators were probably rushed. They probably didn't take as much time as they usually do on a protected PCI case. So.
I completely agree. And we used to go as far as to deploy one perclose, actually. In these patients, even though they were sick, we would still deploy one, so we would have a way to get closure later, to protect their vasculature, to be able to tighten that perclose down around the repositioning sheath. Now that Jason Wilmuth has come up with this side port closure thing that allows you to tighten the perclose down, which we'll get to in a different video, I think. We don't have to do that anymore, but I still do it out of habit most of the time. This slide is okay. I think it's a correct. Try to avoid separating the skin tract. I don't know what that means. We make a skin nick and dilate the tract, as I said. I understand that some people have a problem with that because of the capillary ooze, but I think that's easily remedied with some pressure and some lidocaine with epinephrine. So I don't necessarily do that stuff. The rest of this is very true. You really need a stiff wire. You can really lacerate the anterior wall of the vessel, especially if you're even kind of to the side. If you're not perfectly at noon, if you're at 1 or 2, The stiff wire is really your best friend here to not lacerate the artery as you put in the large dilator and the large sheath. And then this is important, I think, if you have to leave it in. Like I said, we don't leave them in as much as we used to, but you really got to be careful with this POA. In particular, people hold pressure over the arteriotomy while they're pulling it out, and you don't need to do that. You could pull down on a perclose if you really wanted to, but I wouldn't even do that because you can lacerate the perclose. I think a little bit of blood back is okay. It'll prevent you from getting a clot there. It allows any clot that was in that POA, if there was some, to kind of embolize out into that soft tissue space or out of the soft tissue space, and then you can adequately advance your repositioning sheath and get it where it needs to go. And then we don't do a lot of forward suture technique. We use our perclose to hold the arteriotomy closed, and we don't lock them, but we have a technique where we use the side porous sheaths, which is on Murmur. And then there's, like I said, we'll go over some side closure, some other stuff that Jason Wilmuth and Ethan Korngold had come up with to help this. But we don't do a lot of this, but I know people who do. We just normally suture ours somewhat down to the skin. We don't put a huge amount of tension forward. I think that actually messes with the angle of the arteriotomy more than it needs to. And frequently the reason we see bleeding out of these is that people are either pushing down on the arteriotomy, meaning pushing the Impella down against the skin, or they actually put too much gauze underneath it and they prop it up too much. And instead of being at the angle of entry 35 degrees, they're either up at 45 or down at 25, and that actually causes an ooze that's worse around the repositioning sheath than if you just leave it at the actual angle of entry. So,
yeah.
And then, of course, the large bore closure options are essentially ProGlide perclose sutures or Manta collagen-based. We are exclusively ProGlide shop for multiple reasons. One is we like to be able to reaccess. We want to be able to take that final picture. We want to know that we have good closure and the smallest or the biggest hole that we have left to close. Even if the percloses were to only be locked on, that would be a forefront sheath. I can hold manual pressure on a forefront sheath in somebody who got protamine pretty easily. And so that's really important to us. But certainly you can use the collagen-mediated closure devices, and they are effective at getting hemostasis.
Yeah, I think the one trick I've learned with perclose, especially with large bore access, is once you pre-close that artery, make sure you harvest that knot out of the arteriotomy. And I think we posted this on Murmur, we've talked about it, but the more I do that, the more I realize how much of a benefit you get in closure and good hemostasis. Because if that knot is just sitting in the arteriotomy and you're pushing a big sheath through, it can tear where the perclose sutures have gone through the artery. And so making sure that you take both of those, the ends of the perclose, you pull them up to see the knot exit the arteriotomy. It should be above the skin if they're not super big. And making sure that you secure that well, I think, is really important. It's kind of a nuance of perclose, but I think it's really important.
I agree completely. And that's all I got for you, Joe. So thank you for having me.
Thanks, Chris. That was awesome. Tour de force. So just to summarize, and we'll have a summary slide when we post this. Number one, best practices for large bore access: know your anatomy, whether it's a pre-procedural CT or an ultrasound, or just taking time to look at the artery and understand the anatomy and where you're going to stick. Number two, visualize the needle entering the artery on ultrasound and co-register with fluoroscopy to see your wire going up, making sure you like where you stuck. Number two, adequate pre-closure with harvesting the suture. You can use one or two up to your discretion. Number three, use a stiff wire. Watch the dilator go up when you put the sheath in. Consider using the long sheath for tortuous or diseased iliacs. And then once you're done, close your best practices. Number one, give protamine once the Impella is out. 30 to 50 milligrams is totally reasonable, especially, make sure you've preloaded the patient with antiplatelets. Number two, you can use the Chris Brown. I love that elegant technique you showed in this video where you put a forefront sheath in after you've cinched down the percloses, not lock them, cinch them down. Look at your anatomy. And then when you close, cinch down the percloses. I think that's fantastic. I think if you adhere to all those, your vascular complication rate will be in the very low single digits. So
absolutely. I completely agree.
All right. Thanks, brother.
Thanks, man. Bye, Joe.